Good afternoon, ladies and gentlemen. Welcome to the last IVUS webinar hosted by the ACIST Medical Center here together with Jurgen Lichthart. My name is Joost Damen, interventional cardiologist here in the Thorax Center. This webinar is brought to you as a quarterly event by ACIST Medical. And we are pleased to present you also today some cases in which we use contemporary imaging and physiology, in this case with a specific focus on high definition IVUS to guide modern PCI. Let me start by introducing the concept of the course. So the concept of this IVUS course is a step-by-step IVUS guided PCI course in which we will use the ACIST HDI system with the Kodama catheter. In the first editions, which are all available online, we introduced the basic principles. We focused on recognizing different types of plaques, procedural planning, and post-PCI optimization. And a specific focus for today will be on recognizing different types of calcium and helping you to guide dedicated plaque modification strategies as may be available within your lab. The idea of this course is that it's really practically oriented, so you will see cases which are sometimes really good, sometimes also perhaps not so nice, but at least according to us, really, but yet have educational value. That said, the critical thing for the ACIST IVUS system is that it's an HD system which allows a high definition interpretation of the vascular wall, which allows a very easy interpretation of the healthy structure, the intima, the media, and adventitia. Only once you are able to appreciate the healthy part of the artery, you will be able to distinguish the diseased components. And that is something that we've tried to introduce within the past webinars. As mentioned today, the focus will be on calcium. The issue with calcium is that it is usually recognized by angiography by most of us, but the point is that angiography is only very moderately sensitive for the detection of extensive coronary calcification, with a sensitivity of 60% and a specificity of 85% for 3 and 4 quadrant calcification. And as you know, the presence of calcium is associated with difficulty in delivering devices. It increases the risk of dissections, hematomas, increases procedure time, and also increases resources, hospital stay, and costs. And last but not least, it may result in significant stent underexpansion, as nicely illustrated here by this OCT case of a stent that was implanted in a napkin ring of calcium, which finally resulted in a heavily underexpanded stent, small minimal stent area. And that is exactly the most important predictor of PCI failure. So as you know, in post-PCI imaging, we look for the edges, we look for apposition, and we look for expansion. And the expansion is exactly the critical part that is the most important predictor for stent failure on the short and long term. That said, the focus of today is on calcium. What I want to do in the next couple of slides is to help you to appreciate that with imaging, you are allowed to appreciate the severity of calcium. Top row you see OCT, bottom row you see IVUS, and the different components that identify the severity of calcium are classified by the angle of calcium, the thickness of the calcium, and the presence of nodular calcifications, which finally can be measured both with IVUS and OCT. So the arc is very easy to measure. Calcium on IVUS is recognized as a bright white structure with a lot of loss of the echo signal, which typically translates in a dark black contour behind the white shadow. In case you still see signal behind the calcium, that means that there is a reverberation arc, as we like to call it, and that may be an indicator for thinner calcium. In case there's no reverberation arc, that is a clear indicator, as seen in the third image on the bottom row, of very thick calcifications. Finally, nodular calcifications or eruptive calcifications, as they may be called in case they have a very, very irregular surface, are also easy to interpret on IVUS, again, because of the bright white structure in the middle part of the, in the superficial part of the plaque. With OCT, it's also easy to interpret the irregular shape, but may in some cases be difficult to differentiate from thrombus, which also has the typical irregular shape of tissue that is protruding into the lumen. Severity of calcium, as mentioned, degree more than 180 to 270 degrees we call severe. Thickness of more than 0.5 millimeters we call severe, or the absence of a reverberation arc with IVUS, because you know with IVUS you're not able to look through the calcium, so you cannot measure the thickness of the calcium, whereas with OCT you can. And finally, you can appreciate the presence of the nodules and the length of the calcification. There are all kinds of different scores that you can use to classify the amount of calcification. I think that could be a topic per se to discuss for several hours. That's not the concept of today. The idea of today is to really take you through these individual components of calcium and help you to make an educated decision on whether this calcium allows stent implantation. Again, presence of reverberation arc, or actually absence of reverberation arc, illustrates the presence of thick calcium, as shown here in this case published in JAG Imaging a couple of years ago. Calcific nodules, as already mentioned, these lumen protruding structures, typically with an irregular surface, that are typically eccentric and are a strong predictor of stent underexpansion. At the end, whatever you do, whatever kind of lesion modification strategy you use, the critical thing is to find calcium fractures. Once the calcium is fractured, the resistance is out of the vessel, and that is the time at which you can consider implanting a stent. So this is critical. You need to be able to interpret the fractures in the calcium, and the easiest way to do that is to compare the post-modification imaging with the pre-PCI IVUS assessment. Finally, this is a very nice publication from the group of Bern with Lawrence Raber, who published in the Radcliffe Interventional Cardiology Review a paper that actually focuses on how calcium behaves if it's eccentric, concentric, or concentric thick. And what you can see, if you have eccentric calcification and you do some ballooning, that the tissue ruptures at the site of the least resistance. So what you can see in figure 1b, where the white arrow is that there is a dissection exactly at the spot where the balloon ruptured the intima and the media. And that's always at the opposite side of the calcific plaque, simply because of the fact that the resistance there is the lowest. If you have concentric calcium and you do balloon dilatation, it's very likely that you fracture the calcium. It's very likely that it will allow you to implant a stent, and it's also very likely that you will implant a stent with a decent final minimal stent area. In case of thick concentric calcium, if you don't see fractures, you see there's a lack of an image in the right bottom of the screen, always refrain from stenting. The plaque is not cracked and the minimal lumen area is still less than 4, refrain from stenting, because in these lesions, adding a stent will, from a physiological perspective, not do any good to the patient. These are some more case examples of how fractured calcium looks. You see the ruptured calcium in the right side. You see on at 12 o'clock, you see clear calcium fractures, and that is something that is also in the video in the bottom right of the screen, clearly visible, with a ruptured calcific plaque with a small cavity and perhaps even a hematoma behind it. Finally, dilating thick calcium. Here you see how thick calcium behaves after non-compliant balloon dilatation, and what you can see is that in this case, a non-compliant balloon didn't do anything. You see still the napkin ring of calcium that was not affected at all by a non-compliant balloon. So this is a lesion that may benefit from additional and more aggressive plaque modification. So far, the introduction, the idea of these courses is that it's really interactive. So please use the chat box to ask questions. I'm going to pass the word to Jurgen to see if he has any additional comments. If not, we go to the first case.
Yeah, it's well, thank you, Joost. Well, about the additional comments, I think it was quite clear. And what is important to say, and as I saw that in one of the slides coming, that you had a number about thickness of calcium, that it's more than 0.5 millimeter, which you can measure on OCT. On IVUS, you can see the reverberation, and the reverberation, I just want to add something. You recognize the reverberation by that you see the same shape of your calcium at twice the distance from the center of your IVUS catheter. That is how you recognize reverberation, for in case that you're a little bit puzzled by that. And you can see reverberation by calcium, and indicating that it's probably thinner than 0.5 millimeter, and gives a good indication of that you have the chance to crack it with a balloon. Or but nevertheless, that is what we see in the slide. If I can show the slide back, please, Rakesh. That you have the
one with the reverberation.
No, the one with this one. One further, yes, one further. Yeah, this one, and that's why we see these imaging basic steps that before you start your PCI, you want to know what you're dealing with, if there is calcium or not, or if you have to treat it, and that's why you do a pre-PCI imaging. And with that one, you just check on your calcium. You recognize it by the examples Joost just gave, and then you determine, what technique can we use best for lesion preparation. Now, whatever technique you do, balloon, rotoblade, or whatever, what you do after you did it, then you make a second pullback to check if your calcium is cracked. And that is often, and that is what we see regularly also, that part is often forgotten. Actually, you see, and then they start doing, and then they're amazed that the stent is there, but the stenosis also. Yes.
We have nice cases to demonstrate the point.
To put this. And just before, if you think it's better, and I think if it's even better to skip the pre-PCI imaging if you already suspect that there is calcium, that you do a pre-dilatation or rotablator or whatever with it, but never skip the post the pre-dilatation or preparation imaging. Never skip that one. And then you know what you're dealing with, and that if the resistance is there. And then, of course, post-PCI imaging, that's always good to check your work. Always check your work. Then I think it's going to the first case. And in this case, Rakesh, we have to switch to my laptop, because there I have the parts in DICOM. We're going to show you a couple of a case with the system of the real system of ACIST, the simulator of that, but we couldn't get all this, the cases in this simulator that has this limitation there. Now here we have a first case, that was an earlier case. We have a male patient, 67 years old. His risk factors were current smoker and positive family anamnesis. His history was he had a STEMI and a PCI of the right coronary artery 1 week prior to when he came for this case, and at that time, it was because they decided at that time to do a stage PCI. And the procedure now will be the RCA was done, and the procedure now is that we deal with the circumflex and the LAD. Now let's take a look to the angiograms. This was the primary PCI of the right coronary artery. You see they started with the total occlusion or with the thrombus in there. It was STEMI. And this is the final result after the first procedure. So we leave that as it is. That is the information that we can deal with. And now we are dealing with this. So Here we have the left coronary artery, and you see in the mid portion that there was also some physiology measured. So we had in the circumflex, we had the FFR of 0.87. 0.87 is considered non-significant, and the RFR is 0.90. And RFR, for those who are not familiar with that, that's an algorithm used that you can determine severity without adenosine. That's for a later stage in another course, but the RFR cutoff point is 0.89, 0.90. So RFR is a bit borderline. CFR is done and IMR is done for the small vessels. CFR could have been a little bit higher. And IMR, I think it should be less than 20, more than 25.
Yeah, at least 20 to 25.
25. So this is, in this case, good. So that gives that the small vessels, what we cannot see in here, are doing okay. The same measurements were done with the LED. There we have a significant FFR, 0.75, and an RFR of 0.77. Actually, if I see this and we have an RFR already for 0.77, I think that make an FFR maybe, we know already. CFR 1.4, and EMR also is not what it should be.
So you have one
Yes.
second. So so this I think is interesting. So of course this course is not on physiology, but we treated the right here in this first primary PCI setting, and then encountered the disease on the left side. And as you know, there's a lot of debate as to whether you should treat these lesions with a angiographic glasses and just treat everything above 50%. Yeah. Or that these lesions may warrant a physiological assessment and perhaps, may not all be treated and perhaps even result in better outcomes as just presented in the FRAME AMI trial. So there's a lot of debate, but at least we measure. And the funny thing, if you measure also with an academic perspective, we measure always the full spectrum. And if you can show back the edge of the left side, we found so the previous slide, you see that the more you measure, the more discrepancies you get. So the FFR of the circumflex was non-significant, which is the case for most 90% of the circumflexes, I would say. But the CFR was low. So a CFR below 2.2, 2.5 is abnormal. And in the LED, there was a clear significant lesion in the proximal part. Also, again, with a decreased CFR, so something that you would expect. If the FFR is significant, you expect that the flow is low. So that said, we brought the patient back 1 week later to do a staged PCI of the left side, and you could argue, well, the circumflex was FFR negative, so we can leave that alone. But the problem was that the lesion in the LED was at the ostial part, making us leaving us with a high likelihood of stenting the ostium of the LED and the left main. So that's why we also at least wanted to get a better appreciation of the plaque in the circumflex with IVUS.
Yeah, let's have a look then. Well, what we see is not the ACIST console in here, but I bring this to you with our DICOM viewer, which is always good. So we started in the distal circumflex, and what you see in the first picture already here, that we have an eccentric calcified lesion, and I call it superficial calcium because the calcium is in contact with the lumen. And what you also see here, there is some reverberation in here. And look at that, you see the distance from the middle part of the IVUS catheter to the first leading edge of the calcium, and exactly the double the distance. You can see the same shape, however, it's a bit weakened in there, you see there, and this is what we say is reverberation. That means that this particular calcified plaque is, we can consider that's less than 0.5 millimeter thickness, approximately. It will never be a complete quantified stuff. So we continue to proximal, and you see that the calcium is still there. And here we have an eccentric, more mixed plaque, also calcified. It starts already to look a little bit like a calcified nodule that comes inside in here. Not the nicest one that you saw on the former slides. And here we have the minimal luminal area in the vessel. There is some calcification there. There is some lumen in here. And so you see that the vessel itself, although it was not significant on the FFR, it has still a small lumen in there with a calcified nodule. So if we go more proximal, you see that I call this always a diffusely calcified vessel because it's almost to the entire length, except here more proximal in the circumflex where we get near the ostium. We have at 11 o'clock, we have obtuse marginal in there. And in the proximal circumflex, also there we have this calcified more than 180 degrees calcification. The difference in here, what you see is what we do not see here is now reverberation. It's completely black in here. So, and no extra line behind there. So this indicates that we have to do here with some thicker material. And more proximal, again, near the ostium. And here what we see here that the guiding catheter is quite selective. So we do not see the bifurcation with LED. So Joost, I think that I will measure just for the record a bit the minimal luminal area in there.
So for those who say, well, this picture is difficult to interpret, Jürgen. So what would you recommend? I always look at this on the proximal reference in order to get an appreciation of how it should look like.
Yeah.
But in this case, you see white, you see calcium.
Yeah.
But I mean, I think most of the people, if you would have said there may be some thrombus, people would also have believed it.
Yeah, I think so. But in this case, I do not believe that there is thrombus, and I can tell you why. First of all, we focused now a bit on calcium, didn't we? And we say the calcium is white with a shadow, with reverberation. But of course, we have more plaques than calcium alone. So there is one thing, and we discussed it in one of the former sessions, and you can find that back if you look at the videos. But if you have plaque, I see always three types of plaque what you can put on your backbone. First of all, what I put here the calcium a bit. First of all, if you want to determine plaques, you first look for the total vessel. Where is my vessel? The vessel is here. The outside of the vessel here has a certain brightness. If you have plaque and that is just as bright as or brighter than your reference density in here, the surroundings in here, then it's calcium. If you find plaque that has no shadow like the calcium, but is darker than your reference density, then you can consider it what we call fibrofatty, lossy, and it will have less resistance. If you have it as bright or as bright as or brighter without a shadow, then we call it fibrous plaque. And also there, fibrous plaque is also more stiff and will have less movement, but it's easier to crack than calcium. And the calcium we saw with a shadow. I think on the way we will find a couple of pullbacks where we have all the three types of plaques in there on the way. And in this case, this one is diffusely calcified. So
this is interesting. So please remember the physiology. The FFR was normal, the RFR was borderline, was 0.9, and the flow was abnormal, 1.9. That fits with the IVUS.
Yeah, that fits with the IVUS.
So this is interesting, and I think when in doubt, I have in case irrespective of the cases I do. If I do physiology and I don't get what I measure, I use imaging, and that really helps you to better appreciate the disease severity. Obviously, knowing that if you use imaging, there's a 20% higher likelihood that you will put the standards compared to physiology. But if in case you don't understand it, I think the imaging really helps you to better appreciate what you're looking at.
Yeah, because imaging is part of your instrument also, like physiology. The first part of your instrument is your patient that comes with complaints, with your ECG, your blood test, your stress test, etc. That gives you already an indication. I always call that the cardiologist did his homework before putting the patient on the table. And all together with that, then you say, well, that's the likelihood.
Yeah.
Yes. And we never take things for granted. Actually, not only the physiology, but also not always the imaging.
That's correct. You always need to be critical.
Yeah.
So Jurgen, we continued. We did the pullback of the circumflex. Heavy calcification.
Heavy calcification.
So I think, you wanted to measure the minimum lumen area.
I'm going to measure that.
Just for those who are not convinced this is significant, so always remember that the catheter has a diameter of 1 millimeter, so that gives you already an impression on how big this residual lumen area is, and this is small.
This is small. I think here in movement, I see that there is some plaque. I have 3.77, and to indicate that how small it is, this is distal, and it has already plaque. And I will make also a measurement here, and then you can appreciate. We have here 6.24 square millimeters, so it's almost half. So its area is more than 50%. I think I would have drawn the lumen even a bit smaller, Jurgen, at the side of the minimum MLA. But I think the plaque was we concluded that this lesion was significant based on the fact that the MLA is small. As you see, I think I would have drawn it even maybe a bit smaller. It's true, but also here we have a little bit.
It's difficult to see,
because the guide wire is a bit hampering us in here. And we have also, and that is also one thing, you see, we start from one thing in the other, that also here I suspect that there is a tiny air bubble in the catheter, and that makes it so that please take your time to prepare your catheters before you put them in. That's because it hampers a bit your imaging. And always,
Next.
So next, what we did next is that we did a pre-dilatation in the circumflex.
The trio non-compliant balloon.
Trio non-compliant balloon. Now let's see what this has for an effect. So we have the IVUS again.
And now remember the pictures we've shown you in the beginning. That the balloon will create the damage on the opposite side of the vessel.
Now we'll see what it did. Here we start again more or less on the same spot. Here we have here we reach our minimal luminal area, and you see that nothing much happened in here. Also, this part here is still intact.
So this image is actually better than the first pullback. But you see that the lumen area is way smaller than 3.
Absolutely.
This nodule is gigantic. And wasn't affected at all by the trio non-compliant balloon, which actually looked relatively well expanded in the fluoro. So putting a stent here would have been a disaster.
Exactly, and indeed, but you should not have to feed all the people that think, well, I did a balloon and let's do it even. And actually, Joost, even if they see that, if they see this, I did a balloon anyway, so it will be there. So don't step into that. You see, that's don't let you be tricked in there. So in this case, then this we're not happy.
No, we were not happy in this case. Actually, nothing happened, and we consider this patient to be a good candidate for shockwave. Obviously, this is all arbitrary. I think there's still a lot to learn on which device for which indication. In this case, I think a rota or a orbital atherectomy might have been a alternative that would have definitely made sense because of the nodular aspect of the calcification. But what we've learned is that also with shockwave, you may be able to do some proper lesion modification in calcific nodules. And whether that was the case, Jurgen, please.
I'm going to show you. Look, here we managed to get a little bit more deeper in the circumflex. And I just want to show you this. This part here, you see this is darker tissue than the surroundings. This we call fibrofatty plaque, or a beginning of fibrofatty plaque. Just because we see it now, then we get. Take it just one moment.
We're going to fix the fact that you don't see the mouse. Maybe that will help you a little bit to appreciate the image a bit better. Small technical hiccup here.
Like you see around 5 o'clock, from 3 to 5. is deze. And in the meantime, well, in this part, yeah. Yeah. Yeah.
Ah.
Oh, there it is. Oh, wonderful. Well, guys, to see if it, there's a little bit delay, but here you can appreciate the fibrofatty plaque in there. So now let's see, because everyone is what the shockwave did, and the shockwave did something. Because if we go now to this spot here, you can't. It's not that to appreciate with the middle luminal area still, but you see that the shockwave at this spot here, it made a crack. There is a calcified nodule in here, and here is something that we didn't see before. There is a dissection, there is a crack in the plaque in here. However, at this spot, I'm not that impressed yet. Yeah. So, and also here you can see that we have here now a dissection, that there is a crack in the plaque where it was attached to the wall. So that means at least here the resistance is out of the plaque.
Yeah.
The only thing is that I'm still not very impressed by the smaller,
by the lumen area
gain in there.
Yeah.
And then you see that it's still.
But that's always the case in our profession, you know. Yeah. There's not much certainty in what we do, and the only thing that you can say is that after the balloon, we didn't do anything. After the shockwave, things improved. Whether it was enough, I mean, you never know. The issue, though, is that in this case, the calcium was already significantly modified. You saw the dissection. In these cases, I would be very reluctant, highly reluctant to use atherectomy, because the plaque is now is floating partly in the lumen area. And there's not much else to do than pray that this calcific nodule is at least partly modified. And I think you should always consider that we're simply not able of taking these calcific nodules out. The only time they go out is if you perforate, and that's exactly what you don't want. So I think this is the best we could do at this stage. And here we proceeded also with a stent, a 3.522. And then post-dilated with a 4 millimeter balloon. In all the previous cases, we've focused a lot on sizing. Critical, find a distal and proximal reference area with the least amount of plaque you can find. That is the excellent landing zone. But the binary rule is don't land in a segment in which the plaque burden is higher than 50%.
Now let's see if that happened or not.
Exactly.
Yeah. Then you see we have a drug-eluting stent 3.522 and post-dilated with a 4.0 millimeter, not an NC in this case. I checked that. That's
I think so.
Yeah, huh? You think so?
Yeah,
NC, you have standard NC?
Yeah.
Then it should be NC in there. That's well, then of course the IVUS after the stent. Let's have a look.
And you may think, you did a lot of pullbacks. That's not realistic. Jurgen, together with Karen here, looks at all the pullbacks we make in thorax center, and he can attest to the fact there are more and more patients with 6, 7, 8 pullbacks, and specifically with the ACIST system, it's appealing to do more pullbacks. You can do pullbacks at the speed of 2.5 millimeters per second, which actually doesn't add that much time, and I think at the end it will save you time because you can simply work more efficient.
We have a 1 of 12 pullbacks last week.
I can imagine. I will not ask you who this case was coming from, but anyway.
Well, here we start again in the circumflex. What you see here again, there is this plaque, and we see here it's a little bit brighter and darker. So this fibrofatty is adequate in there. Compare it with the surroundings. This is your reference density, fibrofatty with a little bit more fibrous in there. So, but that's for the information. Now we're going to see the stent. I'm going to go back on this spot a couple of moments later. But first, let's see the stent. The stent in here here you see the stent, you recognize it to the spots in there. Now, what we need to do first is there are three important things for that. I always call the minimal luminal area in the stent, and that tells you something of deployment. I always look at apposition in there, but also we look just outside the stent for the plaque burden, and we want to have this plaque burden less than 50% outside.
Maybe we can start with that.
Let's do it in here. Now here we have we're just outside, and the plaque burden you measure within 5 millimeters distal from the stent. So in that area,
or proximal,
or just proximal of the stent, but not a kilometer distal, because that makes no sense. Let's calibrate this.
And you will see you can measure, and in the near future you will get it automatically with OCT. Already get it. At least you get the lumen area. You don't get the plaque burden with the OCT. With IVUS you can see the vessel wall. That's a clear difference with OCT.
So here we see the lumen area 5.29, but now we have to go for the total vessel area. Total vessel area I always measure on the media. I hear voices, EM, etc., external elastic membrane. Forget it, because you can't see that membrane. If you measure on the dark line of the media, then you're okay, because that is always, because there is also your the both membranes. Now I have a problem in here because I cannot look behind the calcium. And it's more than 180 degrees. So this one we have to take with some, how do you call that, with some skepticism, you see. So I'll make a sort of round stuff in here, and then we have a lumen area. Oh, that's red. I will make it a bit bigger. Yeah, that's a bit.
You need to call Rutger, Jurgen, that he changes the colors.
Yeah,
because this annoys me also all the time.
Yeah, but it's also.
But this is clearly more than 50%.
Yeah.
I think this is.
Yeah, I think it's approximately 60%, 65% plaque burden. Plaque burden, by the way, has nothing to do with area stenosis, with the stenosis. Because plaque burden you do on one cross section, and it's the difference between the plaque. And it tells you something about the plaque on a cross section. And as you can see, with this cross section, we have 5.29, and I can tell you this gives a perfect perfect flow.
But what is important is if you go a bit distal, you can see sometimes it's diffusely diseased, and there simply is no healthy reference zone. But in this case, there was. I think if you go a bit distal and take away the measurements,
there we go. Then here we have a problem.
As you see here, there's plaque everywhere.
Yeah, in here. But I see also something else.
On the top, huh?
On the top. Now let's first concentrate on the plaque. Here, see, there's plaque everywhere. Here's the lumen. Here's a total vessel. So you see the plaque in here. But what we see here, and I put this in motion, what we see here that there is behind the media, and it looks like there is a sort of disruption of the media. What we see here, there is an hematoma. So there is somewhere a dissection, and what I didn't see is a real edge dissection on the stent, but it's also can be caused by, indeed, don't forget that we did a pre-dilatation and a shock wave, that the stent was implanted just outside the region where the shock wave was. Now, what we have here is a dissection and a hematoma. This hematoma, I call this submedial, because it's between the media and the adventitia. And what you also see already a little bit, that it starts to compromise a little bit the lumen. Now, in this case, I think this is a very good reason to cover this with a stent. So let's see the rest of the stent. The stent in here, we see a good apposition. We see there is calcium behind. That's why we have here still a little bit oval-shaped lumen, because of the calcium in there. You're not removing the calcium. Here we get also here, and where there is less calcium, there we have a more circular lumen in the stent. And here the stent just overlaps a side branch. Yeah. And here we're outside the stent struts, and here you can discuss if we have here, we have a proximal edge section in here, but this is what we call subintimal because the media is still intact. And I'm not that impressed with proximal edge sections. I'll explain later why not. So that means that in this case, you want to place another stent distal.
Yeah, so if you go back to the case.
Yeah. Then.
You see, we sized this on IVUS, but yet we missed the distal part of the plaque, and we ended with a small dissection and hematoma. So again, a reason to repeat the imaging.
Yeah.
If you have the catheter already on the table, it is already flushed, you simply move it forward and you can use it for an infinite number of times. It will take you less than a minute. And as you can see in this case, it really helps to differentiate a proper stenting result from a not so proper result.
Yeah.
And that matters is illustrated now by at least 6 to 7 randomized controlled trials showing the superiority of IVUS-guided PCI.
Yeah. And this less than a minute saves you hours, I can tell you. Yeah. Well, you see, 3.99 post-dilatation.
Yeah.
Yes. And here we have a final circumflex. I gave already away that's a final circumflex, but...
Yeah, so what also helps here with the IVUS is that we found that the ostial circumflex was really healthy. So we had an excellent landing zone, and that is, I think, a tremendous benefit in terms of deciding on the stenting strategy for the left main towards the LAD at the second stage, because there's for sure no need to go for complex two-stent bifurcation stenting. And I can assure you, you can read 50 times the EBC consensus paper. If you use imaging, you can make an educated guess on where you want to land your stents. And as long as you think that you should not land your stent within a disease segment, you will be good irrespective of whatever kind of stenting technology you use. But you need to look for it. If you just use the angio, you will never be able to appreciate whether you cross the proper start, whether your pot is effective, whether you need kissing balloon, and so on. So I think to me, the IVUS is the ultimate bifurcation stenting tool.
Well, I see here, I did the plaque burden, 5.13.
Yeah, so this is
40%. Yeah, 40%, less than 50. See, so this is what you want.
Yeah, and this is, I mean, in this case, this was as good as it gets.
Yeah.
If you go a bit more distal, you can see that there's hardly any space where the plaque burden is less than 40. See here as well. Here it would have been perhaps even a bit better, but at the end, I think it's this is very much acceptable and nicely covered the dissection.
Yeah, and what's nice about this plaque burden of less than 50, it's already calculated and published that if your plaque burden is less than 50%, the lumen size was the original vessel size, because that's what because after 50%, then the lumen starts to get smaller. And that is so. Don't bother then measuring from media to media for your stent size, etc. Forget that. Go for an area with if you can find that of less than 50% plaque burden, and then you can safely take your size of the lumen size. So as simple as that. Now here we have our distal stent, and you can appreciate that it's nicely round because we have here an area, a region without much or without calcium. So you see that it's nicely circular. Then here around here we have the overlap. We have the overlap of the two stents in there, and then if we continue, then we see what we already saw, that we have a good apposition, still a little bit oval shape, but we're not removing the plaque. And that especially with this eccentric plaques, it's very difficult to get it completely round. And here, and we said that you see that the edge section proximal is still there, but we're not worried by that, because there is not a huge flap in there, and because of the stream, the flow, the direction, that is flap is pushed against the wall and that will heal. Distal edge sections is another story, of course, because they tend to fill if they are because of flow. And here we stop the pullback and called it a day for the circumflex.
Yeah.
Yeah.
So we had to do the LED.
Yeah.
And according to virtually routine practice, we started again with the pullback of the LED.
Let's do. There we go. No questions yet.
No, so please, for the attendees online, use the chat box. Please don't hesitate to interrupt us in case we say anything that is unclear or doesn't make any sense or whatever kind of things. Please don't be reluctant to ask and type your question in the chat box.
Yeah, we're here now. So
we're here now anyway.
Yeah, we're here now anyway. Well, let's see the IVUS pre for the LED. And we start in the distal LED, and the distal LED, very often the distal LED is quite normal. We have here some interval thickening in there, but this is always quite nice. And more proximal than we see here. This is an example of, again, fibrofatty plaque, darker than the surroundings. And in here, also here more proximal in mid LED, we have again eccentric superficial calcium without reverberation, by the way. And more proximal, we will find the minimal luminal area, and that is more in the proximal near the ostium of this. You see at 3 o'clock is a circumflex. And here we have a region that I want to measure for the minimal luminal area. And
yeah, so what did we learn? So we have a distal healthy reference segment. We have calcifications that are mostly eccentric. What we learned is that the ostium is diseased, and that's actually now where Jurgen is measuring. So that confirmed the thought that we had to stand LED towards the LED and not attempt to land in the ostium of the LED in this case.
Anyway, we have 4.98. I'm not that impressed actually. It's and it's then have a let's see, because don't forget the LED seems to be significant.
With FFR, it was significant.
Yeah, it was significant. Now let's see where we can find a spot. Yeah, maybe here. Here at the bifurcation, that's the border with the mid LED. And what we see here, I put this in motion. Here I have plaque, but there is here, you see here I indicate a border, a line, a border, and in here we have, and if you compare it with the movement of the blood speckling in this spot, and you see the appearance of this spot in there, it's more rough and it's laying against the wall. And I suspect that we have here what we call subacute thrombus. Thrombus is another subject for a course in there. But what you see here, thrombus is always on some point against the wall. Yeah, and I see here on the wall, I see some thrombus attached to the wall, and actually compromising a bit the lumen. Let's measure this. I don't know what they did, what happened in here, but let's see what we have. What I go outside the guide wire. The guide wire is in here, and then we have 3.8. It's a bit smaller, but let's go to our normal vessel. Think of 3.8. Now I have a normal vessel in there. And I have another trick for you. 6.75. And now I do another trick, and that is not much done nowadays, but that's from the past, and I'm an old man, so I can show you a couple of things from the past. I know now, I measure now, you see the total vessel from media to media, the length in this more or less normal vessel. And what we have is 3.30. And according to a paper of Ichik Ben-Dor, that what we had 3.9, then if this is if the 3.9 square millimeters lower than this 3.3, then it's very likely that you will have a positive FFR in there. Sometimes I do this trick. But nevertheless, you see it's because of the thrombus, there is some significance in there. Even here it can be even worse, but let's see what happened.
Yeah. So again, what are reasons to stent based on physiology? Based on physiology, we say, it's simple. It's traffic light medicine. If the FFR is below 0.80, we stent. If it's above, we don't. And if the RFR is below 0.89, we stent. And if it's above, we don't. But imaging is a lot more complex because you need to look at the minimal lumen area. In the past, I was always thought, if the MLA in the mid LAD or circumflex or right is below 4, then it's relevant. And then if the MLA in the left main is below 6, it's also relevant. But in reality, I think it's a bit more complex. And that is also reflected in the most recent trials, like Flavor, for instance, in which different cutoffs were used. A cutoff of less than 3 was called significant in terms of MLA. If the MLA was between 3 and 4, well, we were supposed to look at the plaque burden. So that is one criterion. So MLA between 3 and 4 also look at the plaque burden. If it's above 70%, the plaque is significant. And that is then again based on the prospect trial that looked at the vulnerability of plaques with a volume higher than 70% and demonstrated that these plaques are more likely to cause future adverse events. Second, there's another parameter that you can use, and that's one I use typically with most of the IVUS systems we have in our lab, is the area stenosis. So you look for distal reference segment, measure the lumen area, but again, pick the reference segment at a spot where the plaque burden is minimal. Remember the area. For instance, if the area is 8, you go to the side of the minimal lumen area, and then if you measure 2 point something, you know that the area stenosis is above 75%, and that is also an indicator of a severe plaque. So always look at the MLA in perspective to the reference area, because if you have a very small distal circumflex and the minimal lumen area is 3.1, but if the distal vessel area is 3.9, then this plaque is obviously or very likely not hemodynamically relevant. If you have a minimal lumen area in a left main of 6.1, whereas the reference area is 20, I would dare to say that this plaque may be of relevance. So always put the measurements you do in the context of common sense, and keep these few simple rules and regulations in mind.
I just want to go back to one slide because I forgot almost to look at the left main stem. And because here are the angiograms again, and you see at this spot here and also here we have our doubts. And that is why it's so important that you remove for your left main, that you remove your guiding catheter a little bit. Let's see at the left main. I measured, of course, 4.98 at the ostium of the LAD. But then what's also there, that we have also
a nodule
in the left main stem in here. Here with the left main, we have here the circumflex. And I expected the left main a little bit longer visible, but of course that often in the left main your IVUS catheter is a bit tilted, it looks to different sizes, and also sometimes and that is the case in this, but we see a nodule, calcified nodule in the left main in
and
there.
Exactly at the carina, right? Because what you can see is the 2 wires. You see the wire at 9 o'clock that is moving from the left main into the circumflex. So if you have 2 wires, the interpretation of the carina is always easier.
You see.
So that means that the distal left main here is heavily diseased.
This is still distal left. Actually, we see here, and that is what this was the ostium. Here's the circumflex.
Yeah.
And then we have here the distal left main.
Yeah.
Yeah. Now let's measure this one. 5.5. And what we say here is that, and then we go also to a paper that compares the left main with FFR, that below 6 square millimeters, depending on what part of the world you live, then it's very likely that you have a positive FFR.
Yeah.
Now there is some discrepancy because it was positive in the LED and negative in the circumflex, but nevertheless 5.5, I think that is with the calcified nodule.
Again, the plaque burden here is substantial.
Yeah.
It's even difficult to distinguish a healthy reference segment within this left main.
See this and a nodule at the ostium in here. So that explains that this distal part with a bit of thrombus was left alone, but the treatment was a 4.26 drug-eluting stent after pre-dilatation with the NC, and then a post-dilatation with 4.0 and the pot with 4.5 millimeter NC, and then this is the final from the LED. So we start now more proximal in the LED. We see then the diagonal branch and a septal branch coming in from both sides. There is a stent. And you see the oval-shaped stent due to the eccentric calcium. Then here we have the circumflex. The stent is, in this case, jailing the circumflex, and you can appreciate that the wire comes in from 3 o'clock.
But what you can appreciate, and I think this is critical, is that you see the circumflex is a huge branch, right, Jurgen?
Absolutely,
It comprises almost 30% of the circumferential area, which is what you expect based on the angio. But this illustrates that the ostium of the circumflex is nice, open, and patent. And you could argue that if you consider that the ostium of the circumflex is at least 4 millimeters in diameter, and if you would do a kissing balloon with 2 trio balloons, you crush your struts towards one side of the carina. You hardly ever take the complete distal strut, and then I have a very difficult time to believe that the crushed struts are better on the long term for the patient than these nicely aligned struts in the shape that they're supposed to be. Crossing the circumflex.
I recently saw an example that indeed what supports what you say now. That's for patient. Well, actually about reverberation, guys, also stents can reverberate. You can see here the reverberation of this strut, and here you see the reverberation of this strut. Again, double the distance from the struts in there. Now, let's measure now the minimal luminal area in the left main. And this was around this spot in here. Well, that's 10.
9.8.
9.8. Well, that sounds better than 5.5, doesn't it?
Absolutely.
Yes? So I think then this was, and of course we looked at edge dissections. Now, in this case, we do not have an edge dissection because the stent is protruding here in the aorta. By the way, guys, always a reason to mention that in your cath lab report or in your letter, because that is good to know for if this patient comes back for catheterization with a colleague of you, that he knows that there is a stent struts are protruding. And of course, we checked. You have to check in here. Here's the edge of the stent, and you see here. I dare saying that we have less than 50.
Yeah, I tend to agree.
Yeah, you see. So this is okay. And now with this one, we really called it a day for this patient. And these are the final angiograms. And you see it looks more, I think that we will have a happy patient in this one.
Yeah.
Now, this brings us, everything okay there? Because it's so silent there. No questions,
No, I don't see any questions.
Is anyone there still?
Maybe we talk too much.
Yeah, I think so, yeah. Anyone typing in that they're okay and not falling asleep? Yeah, I think then we can go to case 2, I think.
Yeah, case 2 is another. It's a nice case. Case 2 is a case that is. It's about a patient with a inferior STEMI, 68 years of age, dyslipidemia, hypertension, family history of cardiovascular disease, had a PCI some time ago, and then he presents in a referring site with a inferior MI and gets a primary PCI.
Yeah.
And I think, Jurgen, you asked for the images from the referring site,
correct,
right?
and I got them.
Okay,
yeah, and
then let's show them.
Yeah, I got them. Yeah, you see, and this was the other side that was 3 weeks before. Yeah,
for the procedure that was done within here in Erasmus.
So this is how she presented with us, and then this is the previous procedure. This is what we got from the referring site. Now you see, they called it CTO case. And I think that already on the angiogram, we see that it's very likely that we see some calcium in there already. Well, and after some struggling with the wire, they passed with the wire, and that resulted in this angiogram. And here it's even more clear that you can see that it's very likely that we see on the angiogram already some calcium. So what happened is there was a pre-dilatation done, and this was the balloon of the pre-dilatation. And in the letter itself, there was no size, but you can see it's quite small. Then after that, immediately a drug-eluting stent of 3.518 and post-dilatation with a 4.0 millimeter NC balloon was done after this. And then here we have the final result. There was no IVUS was done in there. This was pure based angiographically. So then the angiograms at presentation with us, we started with the left coronary the left coronary angiogram. Then it's a bit fragile in here, but not much. But the right one, you see at the same spot here, the right coronary artery was closed again. Now, fortunately, a very quick wire passage, indicating that probably that, of course, Temi says it also, that we have some thrombus in there. So fortunately, we had a quick wire passage, and then we made an IVUS pre-procedure. I called pre-procedure just after the wire passage. And also this was a pity because I hoped to put that in the system of ACIST, but it was just too large. It didn't allow. But anyway, I think we're okay. This is 2.5 millimeter pullback. Now let's start distal in the right. Again, you see that we already start with calcification. You recognize it now, the bright one with the shadow in there, some softer fibrofatty tissue on this spot. And then we move up, and we are particular curious for the stent, but not after we've seen this. Here we have a region that I think that we have some migration also of thrombus to this spot. Here we have a minimal luminal area. It will immediately measure that for you. So this may be a point of interest, 2.37, just to keep that in mind. Here immediately we have a larger, so that's why it's I think that is merely thrombus, what we see more distal from the old stents. And you see now we have almost a napkin ring of calcium in there, and we get in the heavily calcified region and see here we have the calcium, here we have the calcium, only here we recognize some reverberation in there. And here we see the stent was in what was implanted 3 weeks before. And now if we continue, then we see here that the stent is absolutely underdeployed. See, we see the struts in here and in here, and here's the calcium, and it's eccentric. And that means the eccentric, that means that your angiogram can trick you, because of if your x-rays go from this direction, then you see the widest part of your contrast, and you will not be able to appreciate fully the stenosis on the angiograms. So we have here completely underdeployed stent in there, and probably that was the cause for thrombosis. And here's some malposition, but that's not very impressive in there. And here we have the proximal right coronary artery.
Was there also a stent distally, or was there just a stent
no,
proximally?
it was just a stent proximally.
This was
see,
only
and
calcium.
this was the pars, the calcium, and I think that here we have the migration distal of the thrombus. What was
so this
there.
was geographic miss plus significant underexpansion.
Absolutely,
yeah. A significant underexpansion due to calcification.
Yeah. So
that's always critical, right?
Yeah,
it's absolutely to differentiate why there is the. I mean, you can measure the lumen, but the lumen can also be small because of significant neointimal hyperplasia or incendiary stenosis, even calcifications in the neoatherosclerosis, that could be. But in this case, you should try to measure the struts, and the struts were so the minimal stent area in this case was 2.59.
2.9,
in the stent that was implanted just 3 days ago. I mean, that has nothing to do with neoatherosclerosis.
Exactly.
And this was just plain old underexpansion due to calcium that was not properly prepared.
Yeah.
So now we have a problem, right? We have a patient with a lot of calcium, metal in front, thrombus,
and
an occluded artery.
And an occluded artery, which we quickly opened. And now what to do? You see, then you start here, distal with a balloon. Yeah, that was this region that we saw. And then more proximal, also the same balloon in the stent. And you see the balloon in there. Now we did, and then of course, it's us, we do a IVUS after pre-dilatation to see, maybe a miracle happened that let's see what our balloon, NC balloon, did here. Now, we started a little bit more proximal. We didn't go that deep, so we see the, I will make it a little bit bigger, sorry for this, guys. So, and here's the calcification. Then we have the stent, and you see the balloon itself, although it didn't do much. You see, still under expansion, and don't be tricked by the fact that I enlarged the picture a bit, but the balloon didn't do anything. It's still underdeployed, and you can push with your whole family against that, but we need to have some stronger stuff. Yeah. So then tried with a 3.5 NC.
Yeah, so the operator in this case was ambitious. He thought, you know what, I'll just try. The 10 euro non-compliant balloon might do its job. But again, I mean, we knew that at the time of the infarct, we didn't know. But at the end, we learned that there was already a 4.0 non-compliant used in the referring site.
Now here it did a little bit more, but actually absolutely under. I'm very glad that the operator checked his work every time. You see that didn't take things for granted. So that is
that's critical.
That's critical. And he saw that, we can inflate whatever we like, but it didn't work. And then we started indeed with the shock wave. The shock wave was done on a couple of spots. I just for an example will indicate that the shock wave I put in here, but also they were in the stent. Let's see. And normally you would say, well, use a shockwave before the stent, but we didn't have everything. So at least let's try to crack the calcium behind the stent to get at least the resistance there, that maybe we can do some with some post dilatation. And actually it worked a bit, you see. Here we have the stent. And there we go. You see, we still recognize the spot in here, but you see it gave a bit away. It's very difficult to see where there were cracks. We have stent struts in front, calcium in front, but nevertheless, if I measure here the minimal luminal area,
yeah, so remember it was 2.9.
2.9, and then we have here now 5.6. 5.6. Well, that is a point for shockwave, I think.
Yeah.
See, that's
so there are only three options in these cases.
Yeah.
One is a non-compliant balloon. Yeah, we confirmed that didn't work. The second, there are four options actually. One is the NC balloon, that didn't work. Second option is the I think the best next step would then be shockwave. It's a low mechanical force system. You only inflate to 6 atmospheres, but then give the pulses which allow almost 80 atmospheres. You can use an OPM balloon, which goes to 40 atmospheres, which is the dual lumen, a double layer balloon, which can go to 40 atmosphere, creates a lot of mechanical force and significantly increases the likelihood of perforation and rupture.
Yeah.
And then finally, there is the laser. Laser is something that is perhaps ideal for these patients. Not so sure how much evidence is there to test the concept in patients with a thrombotic lesion who present with a STEMI. But for stable cases, for sure, which present with these heavily underexpanded stent, laser might be a excellent way out. But it's a device that is very costly and not widely available. But just to know, these are the options we have.
Yeah, what I hear is cheaper to prepare your lesion before implanting the stent.
I think that is for sure the bottom line of the course of today. Be prepared before you implant your stent and do it properly.
Now, in this case here, the operator chose to add a couple of stents.
Yeah.
And
that is open for debate, right?
That's absolutely open for debate. I always say, if you see this, then you must be a brave person to do, or very trustworthy that you can that there will still be movement in this area. Let's see what happens. So 2 stents, 3.533 and a 4.0.9. Well, let IVUS be the arbiter.
Yeah, and please recall distally there was a lot of plaque, which was not covered by metal. So I think the distal stent was for sure. With the proximal, I'm not so sure.
I'm not so sure of, but
that's okay.
Yeah. See here we have the distal stent, and we have here indeed some calcified plaque, but that doesn't matter because we have less than 50% plaque burden. If you don't believe me, then I can measure it for you. We get a sort of carpet design, this isn't it, Joost? And here we have the distal stent. You see, nicely circular in here. Yeah, good apposition. Here is some more calcium. And I think that we reached the region where we have the smallest part of the stent. We see overlap with the older stent. Here we're outside already. Let's see. I think that we here, and you see here the overlap of the stent struts. So in here, and I think it indeed did something. And let's be the devil's attorney in here. Let's make a measurement. By the way, I like very much this viewer because you can do without having to get your IVUS machine inside an office. You can do all the measurements, etc. Very easy. 7.17, Joost. So they really achieved something. And in this case, with 4.09, Maybe not ideal for 4.0, but I think it's now a more better start for the patient to have this.
If you have a minimal stand area that is above 5, that is considered appropriate in most cases.
7.17 in this case, so that's quite nice.
Yeah, it's way above.
And I think that was, so they did another post dilatation even, so he was confident, and you see at the spot of the stent, of the minimal stent, and of course they made a very nice pullback. Still no questions.
Yeah, there is one question. We'll get to that in a second. There's a question about sizing.
Okay, then here we have the stents. You still see that now, I wonder.
And what is already nice is that the system automatically gives you also the Kodama system, the HDI system gives you the longitudinal pullback, and you can already appreciate in the longitudinal pullback here that the result is quite nice.
I think we're here with the, now you see now it's getting difficult from where was it? I think in here. I think I'm going to measure here. Let's do that. Nine 9.1, yeah, 9.1 square millimeter.
Yeah, so I think this is a great improvement. There was a question on, should we decide stent size from IVUS parameters? The answer is absolutely yes.
Yeah.
Within this edition of today, focusing on calcium, we're looking at calcium, how the plaque modifies, how the minimal stent area changes. In the previous editions, which are all available on YouTube and on the website of ACIST, you can look our editions in which we focus on sizing. But in brief, I think the key thing about sizing is only one thing. If you go very distal, Jurgen, to a healthy reference segment, here, stop here. Yeah. So this is the only thing. You go distal to the plaque, you find the nearest frame with the least amount of plaque. You measure the luminal diameter. Again, the OCT people will say, no, you need to use the EEM. Well, we can assure you, if you pick a frame in which the plaque burden is as small as possible, there is no difference between picking the EEM and then go 0.25 millimeter down, or pick the lumen and go 0.25 millimeter up. It's exactly the same. And in this case, you can appreciate that the diameter is 3.68 times 3.15, so that justified in this case a 3.5 stent that was chosen. Exactly. You do the same at the proximal side of the plaque, and the system will give you the length in between. And that's it. That's how you size your stent.
And you see, and you can even read it. It's when I was still young, two guys found this, that less than 50% plaque burden, then the remodeling is like that even your lumen size increased a bit or was the same. And it's by Glakov was a pathologist. He found it the first, that was before the IVUS, and then Hermiller checked his work with IVUS and found exactly the same. So forget this. I don't want to be rude again, but forget the EM if you have less than 50% plaque burden.
I would not forget about it. I think what is important is that you appreciate the difference.
Exactly.
And appreciate the fact that the difference is actually minimal to none as long as you pick a healthy reference segment. And I think that also attests to measuring expansion. So we always say you measure the minimal stent area, and you compare that to the distal reference lumen area. If that is above 90%, if the minimal stent area is larger than 90% of the distal reference lumen area, we say the stent expansion is appropriate. But if the distal reference area is in a segment in which you have the plaque burden of 60%, this reference lumen area is not representative of the healthy reference. So always keep in mind, what am I measuring? What am I doing?
Exactly.
And only then you can properly interpret the definitions and the guidelines that people like us like to give you.
Now look at this, normal vessel 9.28. What did we measure? Minimal luminal area?
Yeah,
was,
also 9.2.
But a little bit less, but definitely more than 90%.
Yep.
Yeah.
Okay, Jürgen, I think we have a couple of final slides on. I think we're nicely on time. We prepared 4 cases. This was the final angio. We have a couple of minutes left. You will ask yourself, well, shockwave is actually, it's contraindicated to be used within for stents with underexpansion. The idea of today is not to give to do shockwave propaganda. I can attest to the fact that we use more atherectomy than shockwave in thorax center. But in these cases, we just selected a couple in which we used shockwave. But it is interesting because in the second case, you can see what happens if you put a stent in a patient in which the lesion is not properly modified. You end up with a stent that is underexpanded, and then obviously your options for plug modification start to become limited, simply because atherectomy is not indicated in patients with underexpanded stents. You may only damage the metal and create huge traumata. If you, we looked at that in Erasmus in collaboration with different sites across the globe, and if we can show you the paper that we published earlier this year in Neurointervention, you can see, if you can show the slides, that shockwave actually can be used for stent underexpansion, and actually helps you to increase the lumen area significantly, both cases with superficial calcification as well as in cases with deep calcification. We thought that in case with multiple stent layers, it would have been less efficacious, but that appeared to be the case indeed, but not that strong. If you go to the next slide, I can do that.
I can hear.
You can see that on average, the minimal stent area increased from 4.3 to 6.45, which was statistically significant. So the average increase in lumen area was around 3 square millimeters, which I think is definitely worth the effort. But perhaps what is important to prove the point of the technology is, next slide, is to look at the increase in stent area at the site of the minimal lumen area, because that at the end is where the critical difference was to be made, and that is also around 3 square millimeters, which was also statistically significant. So on average, within the 27 patients treated within the collaborating sites, the technology was actually worked quite nicely. And it should be said that in most of these cases, I think over 90% post-dilatation with high-pressure non-compliant balloons was performed before the shockwave was attempted. So that said, I think if we, I think it's 5 minutes more to go. I think there's not enough time for a final case. But there is maybe time for a final question or comment from you, Jürgen.
Sure. That's what we saw indeed, that if I would do a resume of what we learned today, and what you said, well, we select some shockwave cases because these were good illustrative cases. Whatever you use, rotablator, shockwave, orbital atherectomy, or just an NC balloon or like that, important key issue is check your work. Did it do what it should do? And if it didn't be reluctant to place your stent before trying to make the result like that. And the second case, you saw a lot of pullbacks, and of course the operator in there started with something that you already maybe could expect that it wouldn't work, but he had the discipline to check what he did and not to step into saying, well, it would be okay and like that, because this patient had a problem in a stent was 3 weeks ago, and he saw the problem like that. And that is and that is important. And I know a lot of people still think that IVUS takes too much time, which I think that is you see, if you prepare your catheter before your nurse or can do that already for you while you place the wire and placement of the catheter and make the pull back, even with ACIST you can go 2.5 to 10 millimeter pull back, but even if you choose pullback speed of 1 millimeter per second, it's all possible in the ACIST system. Then even then, it doesn't take it doesn't take too much time, and you have to take some time to appreciate it. I can tell you, even 5 minutes more time spent on IVUS will save you hours.
Yeah.
Look at this example. If maybe in the referring hospital they would have used the IVUS and saw what they did and like that, probably we didn't have to spend the hours to fix this. And that is, and that is, I think, part of the issue. And if you do IVUS, by the way, guys, I know that there are beginners who that probably you do not use that much. Start using that and make and review them from time to time. Once in 14 days, 1 in 3 weeks, whatever is possible. But go with your team and review them, and then you will see that you will increase your knowledge and increase your skills, and also your IVUS cases go faster during the procedure.
And specifically with these complex plaques, it's we learned so much in the past decade on how you can modify a plaque, what happens, and you learn to appreciate which plaque deserves what kind of attention, because we know all these algorithms on calcium modification strategies, but I can attest to the fact that the vast majority of plaques doesn't need a shockwave or a orbital atherectomy or a rotablator. If you see that the plaque is not concentric, if you see fractures, if you see a lot of reverberations, if the length is not too long, it's very difficult to predict whether these lesions will yield or not with a non-compliant balloon. But in case your devices cross easily, I would always start with a non-compliant balloon. And if you repeat the imaging, you will be surprised in what percentage of cases this is sufficient, and precludes the need for more expensive and dedicated lesion preparation technologies. With that said, I would like to thank you for your attention. Thank Jurgen again for his excellent insights. Thank you for watching this final episode of our IVUS course of 2022. We thank ACIST for making this happen, and we look forward to seeing you again next year for a new edition. Thank you. Enjoy the evening, and bye-bye.
Bye-bye.